students. Today we will be discussing the last part of the pharmacokinetics, that is excretion. So most of the drugs they are excreted through the kidneys. However, the drugs can also be excreted through the non-renal routes. And these non-renal routes are first is liver. They may be metabolized in the liver and excreted in the bile through feces. Second, the drugs can be excreted through the sweat, saliva, and tears. So, through saliva, there are certain drugs which are secreted. They are lithium, potassium iodide, rifampicin, phenytoin. Lithium is a drug that undergoes excretion through all the three, that is, sweat, saliva, as well as tears. Certain drugs they are also excreted through the breast milk, through the skin, the heavy metals like mercury, arsenic, they are excreted through the lungs, alcohol, general anesthetics. These are excreted. Next, coming to an important topic, that is hepatic clearance. So, what is this hepatic clearance? The drug excretion through the liver is called as hepatic clearance. And what is the formula for hepatic clearance? Hepatic clearance is equal to hepatic blood flow into hepatic extraction ratio. Okay, so let us uh, know this by means of an example. If in question it is given that hepatic blood flow is equal to 1200 ml per minute and hepatic extraction rate is given to be 0.5, then the hepatic clearance will be equal to 1200 into 0.5, that will be equal to 600 ml per minute. This will be the answer. So in some certain questions, if the numericals are given, instead of the hepatic extraction ratio, the value of bioavailability is given. So if in the question bioavailability is given and you have calculated the hepatic extraction ratio, then the hepatic extraction ratio can be calculated by hepatic extraction ratio is equal to 1 minus bioavailability. Okay. Suppose the bioavailability is given to be 0.6. F denotes bioavailability. So suppose bioavailability is given to be 0.6. Then what is the hepatic extraction ratio? From here we can calculate 1 minus 0.6 is equal to 0.4. Okay. So then we can proceed to calculate the hepatic clearance. Okay. So this was all about hepatic clearance. Now coming to another important topic, that is enterohepatic recycling. Enterohepatic recycling. So some of the drugs they are excreted via the bile, and when they get excreted via the bile from the liver, they reach the bile, and through the bile they go to the intestine, and again from the intestine they are again reabsorbed. So this cycle is known as enterohepatic recycling. From liver they go via bile, they reach the intestine, and then they are absorbed again. So this is a cycle that gets repeated. So this is known as enterohepatic recycling. So what is the clinical significance of this? It contributes to the longer stay of the drug in the body. Okay. So what are the drugs that undergo enterohepatic recycling? The examples are OC pills, doxycycline, morphine, etc. Okay, so this was all about enterohepatic recycling, hepatic clearance, and what are the various non-renal routes of drug elimination. Now coming to the renal excretion of the drugs. So suppose this is the nephron. It has got a proximal convoluted tubule, then the loop of Henle, distal convoluted tubule, then the collecting ducts. Now here there is glomerulus. So what are the steps in excretion via the kidney? First is your glomerular filtration. Second step is the tubular reabsorption. And third is tubular secretion. So these three things happens when the drug is excreted via the kidneys. Glomerular filtration, tubular reabsorption, and tubular secretion. So first is glomerular filtration. So the lipid soluble drugs, they easily cross the membrane, as we all know. So they cross the glomerulus. Next is the water soluble drugs. They are filtered through the pores in the glomerulus. So the glomerular filtration, it is inversely proportional to the plasma protein binding of the drugs. Glomerular filtration in this case is inversely proportional to the plasma protein binding of drugs. Now, what is the normal GFR of a person? Normally, the GFR is around 125 ml per minute. So, total in 1 hour, the amount of fluid that is filtered through the kidney is 125 into 60, that is equal to 7.5 liters per hour. So, in a day, the kidney will filter 7.5 into 24, that will be equal to approximately 200 liters. Yes or no? But the urine output per day is 1.5 to 2 liters. So what happens to the rest of the fluid? This rest of the fluid, it is reabsorbed. So next thing which we will be studying is the tubular reabsorption. So 99% of the glomerular filtrate that is filtered through the glomerulus, it is reabsorbed. But the tubular membrane, it does not have pores. Pores are not present in the tubular membrane. So what happens? The water soluble drugs, they are not reabsorbed and they get excreted. Also, we know that the unionized drugs, they get reabsorbed and the ionized drugs, they get excreted. So therefore, if the drug and the media are same, the drug, it becomes unionized and it gets reabsorbed. If the drug and the media are different, then the drug is not absorbed and it is excreted. Okay. drug and media are same. In this case, the drug is absorbed. Now, if the drug and media are, different, in this case, the drug is not absorbed. So, what is the clinical implication of this? So, the clinical implication is that in acidic drug poisoning, for example, in case of poisoning with aspirin, aspirin, as we all know, is a salicylic acid. So, in poisoning with aspirin, the treatment is by making the urine alkaline by adding sodium bicarbonate. So, this is an example of post-alkaline diuresis. Also, in case of basic drug poisoning, example, amphetamine, the treatment is by making the urine acidic by administering ammonium chloride, sorry, NH4Cl. So this is known as post-acidic diuresis. Okay. So in acidic drug poisoning, like that in case of aspirin poisoning, the treatment is by giving sodium bicarbonate, and this is known as post-alkaline diuresis. Whereas in case of basic drug poisoning, the urine should be acidified by the addition of ammonium chloride. Now coming to the tubular secretion. So tubular secretion takes place by means of pumps, or it may take place by means of transporters, which are present in the tubules. So the transporters can be organic anion transporter or organic cation transporter. Okay. So these transporters, they are saturable. So one drug can be transported at a particular time. And one of the examples of tubular secretion is that of penicillin. Penicillin is a very short acting drug. Penicillin is short acting, and that is due to the rapid tubular secretion. So to make the penicillin long acting, probenecid is added. And what does this probenecid do? Probenecid has higher affinity for the transporter. And this probenecid has higher affinity for the transporter. So this probenecid, what it does, it competes for the transporter and thus prevents the tubular secretion of penicillin, which makes the penicillin longer acting. So this was all about the excretion. Now the various orders of kinetics is discussed in another video, that is kinetics of elimination, zero order versus the first order kinetics, and what is pseudo zero order kinetics. So that's all about excretion. Thank you.